Okay, so we are into the topic called as evidence-based medicine. Hello and welcome all of you to the pharmacology lectures. Now, initially, doctors were relying more upon experience-based approach, where they were experiencing the things from their patients, and depending upon those experiences, they were utilizing those experiences in their clinical approaches. So their experience was a teacher for them. But now it's been shifting to more of an evidence based approach, right? So, evidence based approach is a newer method or where a credible evidence which has been generated through different clinical trials or meta analysis are taken into the consideration for clinical practice. So now it is newer approach where the evidence from well designed clinical studies are taken into the considerations for clinical decisions. So from experience based approach we are going into evidence based approach. What is evidence based medicine? So it's basically a systematic findings evaluating and using contemporary research finding as a basis of clinical decisions. That we'll see in details, that it's a systematic studies which has been done in patients in a proper way with guidelines, and because of those authenticity of the studies and the results, we are utilizing those results in our clinical practice. So that is evidence based medicine. So, if we divide the evidence based medicine hierarchy, it comes with grade 1, 2, 3, and 4, where we'll start with grade 4. Which kind of studies or research are considered in grade 4 category? So, these are case reports, anecdotal reports, and clinical experiences. These are considered in grade 4 of evidence based medicines, and these case reports and clinical experiences published studies are comparatively less reliable, but they serve as a signal. So they serve as a signal or the pointers to initiate a research study. So these are not authentic, you cannot always rely upon them, but they can be a pointer or they can serve as a pointer or a signal that this is possible. So proper clinical research is needed in this aspect. So these example of case report where in a single patient, if something happens and if clinician observes, he can publish this kind of studies. It is a case of systemic lupus erythematosus in male patients in lower Assam. So this kind of case reports where it is been done in only single patients, where you find out accidentally sometime in single patients and report it. For an example, sometimes you observed some urticarial rashes with some XYZ drug and you can report it. So it's not that authentic because it's only been found out in one patient and you have reported it, so it is less reliable, but may serve as a pointer for that you can study in more number of patients. Then if we want more authenticity, we are going into more of an observational studies kind of a thing or some interventional studies kind of a thing. These are open label trials, we'll see in details. Some pilot studies, observational studies like cohort and case control studies. So these all are more of a grade 3, where again the credibility is an issue, so they are less reliable, but they are again serving as a pointer or indicators for further investigations. So these are case control cohort studies. Some of mostly they would be observing studies and only few interventional, but they are open label. We'll see about those things in detail. Then in grade 2, which are comparatively more reliable. So these two grades, grade 2 and grade 1, are comparatively more reliable. That includes randomized control trials. We'll again see in detail. They are more of a reliable but not 100%. So more reliable clinical decisions you can take from grade 1 studies or systemic reviews and meta-analysis. So they are more reliable. So we have already seen how case report looks like. So that was grade 4 studies where single case is being published or reported and credibility is not that much. Now we are going into grade 3 studies, and these are more of an observational studies, includes two major kind of studies, that is case control study and a cohort study. So difference between this case control and cohort is very interesting, and that can be very fruitful to you if you understand the basic concepts of both the studies. So let's take this example so that you can understand it better. So these are observational studies, these cohort studies and case control study. Now cohort studies are usually they are prospective because they are going in direction ahead, and case control studies are usually backward studies or retrospective studies. In cohort studies you are going from exposed to outcome, and in case control studies you are going from outcome to expose. Now if I give you a clinical example, that would be more understandable. For an example, exposure, let's take as smoking. So smoking is exposure and outcome is lung cancer, right? So this is exposure, that is smoking, and outcome is lung carcinoma. So here in cohort studies you are going from smoking to lung cancer. So you are finding association in smoking persons with lung cancers. So now you are recruiting persons who are exposed to smoking, and you are following up, and after follow up you are finding out how many develops lung cancers. So that is prospective or forward studies. What is the case control study? Here you are taking the patients of lung cancer, and in lung cancer patients you are doing backward analysis, retrospective analysis to find out how many were exposed to smoking. So this is backward association finding, and that is called as case control studies. So if you understand that much, now it become easy for you to understand the difference. So case control study is usually retrospective. It goes from lung carcinoma to smoking, where cohort study is usually prospective, where you make a cohort of a patients who are exposed, like for an example exposed to smoking, and then you are following up, and eventually you find out how many develops lung cancer. So obviously this follow-up process is long, and you need to do lot of follow-ups, so it requires obviously lot of money, so it's costly and long waiting time obviously. While here you are just retrospectively analyzing the things, or checking the past records, or using the questionnaire, and you are just asking that okay, these are the patients of lung cancers, now let me check how many were exposed to smoking. That you can only identify with history taking only. So that is comparatively cheap, and quickly you can finish this kind of studies. In cohort studies where you are going forward, the study populations is relatively large. You need to take lot many patients of smoking, or lot many persons with smoking, because from that you need to identify how many develop lung cancer. While here the study population is relatively small because you are just taking the cases of lung cancers only, there would be few comparatively, and you need just checking the exposure of smoking. So study population here is small, while in cohort study you need to take comparatively large study populations. Now this is important. Cohort study is appropriate for common diseases. Cohort studies are appropriate for common diseases because you are following up, and eventually you need to find out how many develop that disease. So that disease should be common. If that disease would be uncommon, then it takes lot of time and it takes lot of money to find out the association. So it is not that relevant. So cohort study is only suitable if you are doing research on common diseases. While it is appropriate for rare exposures. So rareness is on exposure side in cohort studies, right? So here you can, in cohort studies, you can take persons who are having rare exposures. For an example, only specific chemical exposure. For an example, only methylene exposure persons you are taking, and you are finding out bladder cancers associated in those patients. So you can take rare exposures, but you cannot take rare diseases. So cohort study is suitable for rare exposures, but it is not suitable for rare diseases. It is suitable for common diseases, and vice versa. In case control, it is appropriate for rare diseases, because here you are going retrospective. So if you even take rare diseases, for an example, you take silicosis, patients of silicosis, and now you are going retrospectively to find out association of silicosis to particular chemicals. So that would be easy for you, because so you can do this kind of studies of rare diseases with case control studies, but it is not appropriate for rare exposures, right? So rare exposures, it would be difficult. So this is how it's a vice versa thing. Hope you understand in case control and cohort studies. So these were some of the major differences between cohort and case control study.